بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. I'm Dr. Ali Mohsen, Medical Manager of Asino Company. And first, I'd like to welcome all of you and thank you very much for attending our scientific webinar entitled Neonatal Infection Secrets, held by the Pediatric Department in Al Anbar Medical College in cooperation with Asino Company. Today, we shall have valuable presentations by two distinguished speakers, Professor Yahya Al-Ithawi and Professor Nu'man Nafi' Hamid. Before beginning, Dr. Nu'man has a word to say, so please, Dr. Nu'man, the mic is yours.
Assalamu alaikum wa rahmatullah. Good evening. Just I want to say a few words in Arabic. إنا الله وإنا راجعون. كل نفس ذائقة الموت. الحقيقة نعزي أنفسنا بوفاة الأستاذ الدكتور محجوب النداوي. إنا الله وإنا راجعون. الله يرحمه ويغفر له ويسكنه الجنة. كان أستاذ وكان طبيب وكان مربي وكان كل ما يوصف به من الصفات الجيدة، وندعو له بالمغفرة والرحمة وفسيح جناته. وأدعو الحاضرين لقراءة سورة الفاتحة مع الصلاة على سيدنا محمد وآل محمد.
شكرا جزيلا أستاذ نعمان. Thank you very much for those nice words. Now, allow me to start our scientific webinar by presenting our first speaker, Professor Yahya Al-Ithawi from Canada. He is a consultant neonatologist, a researcher, and a scientist. Also, he's a visiting professor and the director of the Arab Board of Neonatal and Perinatal Fellowship Program in UAE. Professor Yahya, you can start your presentation, and thank you in advance.
Well, first I would like to say also a few words. أستاذ محجوب النداء يرحمه الله ويجعل مثواه الجنة ويتقبل منا ويتجاوز عنا. كان رجل وإنسان وطبيب وإضافاته كبيرة ومشهودة لطب الأطفال، وهو صديق الجميع، فالله يرحمه ولا حول ولا قوة إلا بالله. Second point is I would like to thank the organizers for this webinar. And in this talk, I know antibiotics are very debatable, from not use to overuse, and especially in neonatology, this era of very fragile group of people. They are vulnerable to infection, and it's considered one of the main cause of morbidity and mortality in an ICU, and for those also out home. So what I try to do to put some shine on this type of debate by introducing cases, and I hope the audience can give their feedback before I say my words, and it's all open for discussion. I know there will be controversy. I know there will be disagreement. I know there is a difference in practice depending on the facility and the country. Especially we have audiences from all over the world, from Mexico down to Iraq. This is simple. I want to say that although this webinar is organized by Asino, I don't have any connection with them. And I'm not here to advocate for any types of antibiotics rather than talking in evidence-based medicine. However, we know that in neonatology, about 80% of what we do is without evidence. So let me start with the first case, and I hope that you guys try to answer the question. So we have a 30-week male baby born to a mother with pregnancy-induced hypertension. After delivery, by 30 minutes, the bring you start to have tachypnea with desaturation down to 70s. The neonatologist started CPAP and then managed the respiratory wise or the respiratory support accordingly. So what will you do in the first option if the baby born normal vaginal delivery, but by induction, there was no spontaneous labor. And remember, he is 30-weeker. What you will do? You will do full sepsis workup and start antibiotics. You will do partial workup with no antibiotics, or no sepsis workup and no antibiotics. So please start the case one, option one poll, and let the audience answer. So you give the audience for about 30 seconds. So please answer, select your option. 30 seconds. So will you do full sepsis workup with antibiotics, or partial sepsis workup without antibiotics, or no sepsis workup, no antibiotics? Okay. So we have about 55% for the first option and about 28% for the second option, which is, very good, because I will do, I would disagree with everybody. I will not do sepsis workup and I will not start antibiotics. And the reason for that, this mother is a pregnancy-induced hypertension. Although the baby is 30-weeker, but there was no risk factors and there was no spontaneous labor. So the baby born premature, not because there is a risk of infection, but because we decide to bring him out to this. And once he's born, he has some either TTN or RDS. So for me, option one is none. Now, should I do partial sepsis workup or no sepsis workup? Now, this depends on many things on the setup. But in my unit, I will not do sepsis workup and I will not start antibiotics. However, I can say that some units will start because of their infection control status. Remember, this baby is premature, but he has no risk of infection. So there is no setup for infection. So I would go with option number 3. Same baby, but delivered by C-section for maternal reason. And again, the first was delivered by normal vaginal delivery, but now same baby delivered by C-section. So please answer option 1, option 2, or option 3. So same story, 30-weeker, C-section, no labor, have some tachypnea and retraction by 30 minutes and started on CPAP and managed accordingly from respiratory point of view. So will you do full sepsis workup and antibiotics, partial workup with no antibiotics, or no sepsis workup, no antibiotics? Give them, please, 30 seconds. Okay, so 48% for the third option, which is great, because that's exactly what I will do. Remember, please, that antibiotics can save life, but also antibiotics can kill. Overuse of antibiotics is one of the pillars of developing necrotizing enterocolitis. And remember, this baby is 30-weeker. He's not going home. So you're monitoring the baby. If the baby deteriorate or not improve, or always you can start antibiotics. But with this scenario, I will not start antibiotics and I will not do sepsis work. Now the third option. So same story, but deliver after spontaneous vaginal delivery, following a labor mom, and mom who got in and the baby delivered by 30 weeks of age, and at 30 minutes of life, he got tachypnea, desaturation, started non-invasively on non-invasive respiratory support. So will you do sepsis workup and start antibiotics, or just partial sepsis workup without antibiotics, or no sepsis workup, no antibiotics? Please give them 30 seconds. Option 1, option 2, or option 3? Okay, you can show the result. Okay, so we have some kind of everywhere answers, 30, 36, and 35. Personally, I will do full sepsis workup and I will start antibiotics to rule out sepsis for 48 hours. The reason is I do that because the mom was in spontaneous vaginal delivery. She has pain, and we know that sometimes the message to start deliveries might be due to infection. So the baby born prematurely, not for maternal reason, but because of actual labor pain, which means the possibility of infection is still there. So in this case, I will do a full sepsis workup. I will do one side blood culture. I will do CBC. I won't do inflammatory markers. I will start ampicillin and gentamicin. I will give the antibiotics for 48 hours, and I will wait the culture. And the reason for that, again, there is risk of infection. So you have risk of infection, which is the pain of the delivery, and you have prematurity. So I have two risk factors. I think that mandate to start antibiotics to rule out sepsis. Now, case number 2. So you have a 27-weeker born to a mother with pregnancy-induced hypertension, and she was gestational diabetes managed by diet. The baby needed surfactant and giving by Ensure. So they intubate, they give surfactant, and they extubate the baby. To rule out sepsis, a workup done, and the baby started on ampicillin and gentamicin. He's currently 48 hours. Blood culture is negative. The CBC results showed the immature to mature lymphocyte white BC 0.2, and the hemoglobin is 13. The arterial blood gas is good. The lactate from the arterial site is 2.4. He's on CPAP of plus 8 centimeter water, need FiO2 of 21%. They did an echo because he's 48 hours and still not improving. It showed PDA of 0.3 millimeter, so more than 1.6. So they decide to treat. They did an X-ray, and this X-ray showed a wet lung. They don't have facility to do lung ultrasound. The CRP is 42. So what you will do if the white BC is 6,000, the neutrophil is 2.5, and the platelet is 65. Will you stop the antibiotics? We are 48 hours. You will continue antibiotics and do another culture, or change to another antibiotics and do another blood culture. So please answer which option you will go. Give them 30 seconds again. Okay, so we have 57% for option number 2, and about 23% for option number 1, and 20% off. So our answers are everywhere. For me, I will not continue antibiotics. I will stop the antibiotics. Culture is negative. CBC result are benign. The IT ratio is 0.8, although CRP is 42, but doesn't mean nothing. So please, the CRP is only used, in my opinion, for 2 reasons. The first one is if your baby is clinically deteriorating and the culture is negative, and you want to decide how long the antibiotics should go, so you'll do serials. If it's going up, I would go instead of 2 days for 5 days, or maybe 7 days. Or if it's going down, I will stop at. So this is one of the reasons. The second is when it's negative. And when we say negative, mean it's very low. So I would consider anything below 30 is because CRP is an inflammatory marker, and it can be due to RDS, due to ventilation, due to stress, due to asphyxia. It can be anything. So this baby looks for me stable enough, not deteriorating. The blood gas are okay. FI2 requirement is not high. And in addition to that, he has a PDA. So despite he has a PDA, every marker is good. So all this is due to PDA, and I will stop antibiotics. I will not continue. So the second option is the YBC is 4,000, the neutrophil is 2,000, and the platelet is 50. So again, will you stop, continue with another blood culture, or change to antibiotics and do another culture? Option 1, option 2, option 3. And I'm going to answer all the questions at the end. So if you have questions, please feel free to ask. Okay, so we have 45% to number 2, and 29% for option 1, and 26% for. Now, what I will do personally, first, I will continue antibiotics. If I have options, I will not do culture, because the question asks for culture, I will do a culture. But when I do a culture, I will ask for 2 trials. If I don't get samples enough amount, I will not continue, but I will continue antibiotics. So I will do 2 trials for culture. So I will go with the option 2. And the reason is I like the white PC to be more than 5,000. And I like the neutrophil to be more than 2.5. And the reason if I continue, despite its negative culture, is prophylactic. Because this baby looks like, for me, is immunocompromised, and his cellular immunity is not great. And that's the reason why I continue antibiotics. So I will continue antibiotics. If I don't do culture, I will continue until I repeat the CBC, until the white BC goes up, or 5 days, whichever come late. But if I have an option, I will not do culture. But because here's the question asked for culture, then I will go for option number 2. Same story. The white BC is 2,000, the neutrophil is 1,200, and the platelet is 40. So will you stop the antibiotics, you continue antibiotics, or do another culture? Or change the antibiotics and do another culture? Option 1, option 2, option 3. Okay, so 63% to change to antibiotics and do another culture, and 13% only, or 10% only for first option, and about 26% of option. I will not stop the antibiotics, definitely, because the white PC is low. I will not change the antibiotics because the culture is negative. We can continue antibiotics to protect the baby as prophylactic antibiotics. So again, I will continue the same antibiotics and do another culture. And the first option, I will not, the second option, when the platelet was like a borderline, the white PC was a borderline, I will not do a culture. But here, definitely, I will continue the antibiotics, same antibiotics, and I will do another culture. And I will wait until the platelet goes more than 50, the neutrophil goes more than 2.5, and the white PC go more than 5,000. And so the purpose of continuing antibiotics is as a prophylactic, not because the baby is not improving. And remember, the antibiotics is not magic. The baby here has PDA. So remember, his weight, his CRP is high, and he needs CPAP because he has a PDA. And so the culture is negative. You have a good tool. Now, despite that, you have 30% that the culture might be, you might have sepsis and the culture is negative. But how you do that? So if you have 10 babies, because around 30% of culture are negative despite there is a clinical sepsis. So if you have 10 babies in the unit and you have, for example, 10 cultures and they are all on antibiotics and you have negative culture all, then probably you are overusing antibiotics. Because remember, the culture negative. But if you have 7 of them are positive and 3 are negative, then yes, you can continue antibiotics or you change the antibiotics accordingly. But however, here, I will continue same antibiotics and I will do another culture and I will wait between 5 to 7 days until the white BC parameters improve and I'm sure I have a second negative culture. Because the yield of positivity of 2 culture is way higher than 1 single culture. So we have case number 3. We have a 10 baby who's 39 weeks, born after rupture of membrane of 30 hours prior delivery. The baby ended up with spontaneous vaginal delivery. The mother is GPS positive. That was not treated. The mother temperature is 38.2 degrees Celsius, and that was prior delivery. The child was active, no active resuscitation, and when we say no active resuscitation means that we didn't provide positive pressure. We just warmed the baby, dry the baby. The baby kept with the mother for transition and establishing feeding. The CBC from the course showed white BC of 8,000, hemoglobin 17, and platelet 100. What you will do, start antibiotics with full sepsis workup, partial sepsis workup without antibiotics, no sepsis workup, no antibiotics. So the organizer, do have enough time? Please, if I don't have enough time, just remind me.
No problem, doctor. You can continue.
Okay, so we have about 60% to option number 1, which is kind of very sad, very disappointed. Option 2 is 30%, and option 3 is 11%, because I will go with option 3. If the baby even deliver in a sewage, not because the mom is GPS positive and he's febrile, even if he's delivered outside, even if the cord is contaminated, the baby is asymptomatic. And remember, this baby is an NICU. So I will not do sepsis workup. I will not start antibiotics. However, some units, they do only CBC at age of 4 hours when they have GPS positive, which is not a problem because the CBC already done from the cord. I don't need to repeat it. So this baby does not need antibiotics. He's a term and he's asymptomatic, despite he has a prior, he has a prom, and he has mother is GPS. So mother has probably active infection, and the baby is prone to infection. Agree, but he's asymptomatic. His white BC looks great. So no sepsis workup, no antibiotics. Now same story. No sepsis workup was done for this baby, but at the age of 4 hours, he started to be tachypneic. So he started to be symptomatic. Now, what you will do, start antibiotics with full sepsis workup, partial sepsis workup without antibiotics, no sepsis workup, no antibiotics. Please answer option 1, option 2, option 3. Okay, show us the result. Okay, so 77% for option number 1, 20% for option number 2, and only 4%, which is very good because I will do sepsis workup and start antibiotic. The baby now is symptomatic. Although there is possibility that he might have transient tachypnea, But remember, this baby is not C-section, so the risk of TTN is low. Second, the baby mother is symptomatic. So the possibility of transient tachypnea is very low here, although it can occur. But this baby need 48 hours, deserve 48 antibiotics. You have 3 risk factors and he's asymptomatic. So if this baby, for example, asymptomatic and he's 36 weeks, I will do sepsis workup, even if he's asymptomatic, because prematurity is a symptom. So if the baby has 1 symptom and have more than 2 risk of infection, then probably, and this baby has 3 risk of infection. So I will start antibiotics, do false sepsis workup, keep the baby on antibiotics for 48 hours, and look for the baby improvement or deterioration, and look for the culture if negative, and then I decide to continue or stop after 48 hours. Case number 4. We have a 25 weeks baby born to a mother after a clean section. That means the mother was not in labor, there is no risk of infection. Partial sepsis workup was done at birth, and for some reason that I don't know, blood culture at day 5 is negative, and the kid was not started on antibiotics. At age of 11 days, while the kid was on CPAP of 6 centimeter water, and he was feeding express breast milk and premature 24 formula, he was on 5 ml every 2 hours, he started to have some abdominal distension, and he passes some blood stool. The X-ray shows suspicion of necrotizing enterocolitis. The facility there has no option of doing abdominal ultrasound. His capillary blood gas shows some metabolic acidosis, and his lactate is a little bit high, 5. He has a right upper arm PICC line. The PICC line was inserted on day 3. He's now 11 days, so the age of the PICC line is 8 days. He's on TPN in addition to the feeding. After blood culture was done, which antibiotics you will select? So if you can raise your hand, and the organizer will give you the option to tell. We'll ask only 3 people. So if you can raise your hand, and the moderator will give you the stage to say which antibiotics you will select. Do you have any answer, people? Anybody want to answer which antibiotics they select? Any answer? Not chatting, yes. Raise your hand and they will give you the mic to speak. Yes, please, go ahead.
Yes, good evening. In the choice of antibiotic for 11 days, as long as he's having only suspicion of the neck, okay, if he's already on antibiotic, we can change to metronidazole if we are suspecting the neck.
Oh, okay. So what's your name and from where you
Dr.
are?
Elhama. I am from Azerbaijan, Dr. Elhama.
So he was not on antibiotics.
Then we will start the first antibiotic, which we are usually using for the first coverage, ampicillin and cefotaxime.
So you will start ampicillin and cefotaxime.
Yeah.
Okay. Any more answers?
Yes. Yeah. Good evening.
Good evening.
Good evening. Yeah, I'm Dr. Ibuje from Nigeria.
Go ahead, please.
Yes. Well, if he said it's not on antibiotics, the short of antibiotics will depends on the antibiotic sensitivity of the region.
Well, you have the story. There is not. He's not on antibiotics. You have the story. Well, which antibiotics you will select, or you will not start antibiotics?
I will add metronidazole because of the neck. The common organisms are normally gram negative, so the metronidazole. I will add metronidazole. I'll add metronidazole to the drugs. I will start metronidazole, and I will also start on that first line antibiotics depending on the sensitivity of the region. There are no first line antibiotics for intersepsis because of the organisms are region specific. So it depends on the guideline of the region of the region that is occurring. I will start the first line, but I will also include metronidazole because of the organism that cause neck in units. Thank you.
Okay, thank you very much. Any more answers?
Yes.
Go ahead.
Yes. Regarding this baby, you can hear me?
Yeah, I do. Go ahead.
Yeah. Regarding this baby, I can start oxacillin with meropenem and metronidazole for double coverage of the neck and also for the anaerobic infection.
Oh, okay. One more answer.
Hello.
Yeah, go ahead, please.
Yeah, my name is Dr. Ajiboye. I'm calling in from Nigeria. I would place the patient on ampicillin, gentamicin, and I'll add IV metronidazole.
Okay, sounds good. So let me see what I will ask. Thank you very much for the answers. Great. First, I will not add metronidazole. That's one. Second, remember, please, this baby on BREM 24. Also, he's on ABM. So the possibility of cow's milk allergy is there. The second is the baby was not on antibiotics. The third, this baby has a PICC line. So I am not sure. First, I will not go for triple antibiotics. That's definite. You don't need to do that. So here, because I have a PICC line, so the possibility of cones and staph is high. So you need to cover that. And when you cover, most of cones are MRSA, not NISA. So oxacillin is not enough. So I will start definitely IV vancomycin. To cover the gram-negative, I will start gentamicin. There is no need, there is no indication of metronidazole here, unless you have sensitivity. And so remember, he has metabolic acidosis and has lactate is high, and but has a PICC line. So the possibility of, and he has a bloody stool and has abdominal distension and neck. And we know about 50% of neck associated with infection. Not all the necks associate with infection, but most of the necks are associated with infection. And the neck is not only caused by infection. There are three pillars: the milk, the defense, and the enemy, which is the bacteria. I will start vancomycin and gentamicin. I will do blood culture, and I will wait the result. I will not go for metronidazole, I will not go for oxacillin, and I will not go for cefotaxime. There are two reasons. We don't have CNS involvement, and the baby was not outborn. So the community-acquired infection is not there. The possibility of staph and cones is high, and the possibility of gram-negative is high. So vancomycin and gentamicin is the best option, in my opinion. Now, at 48 hours, the culture was negative, but the kid still has abdominal distension and still have bloody stool. What you will do, stop antibiotics, continue antibiotics for 5 days, continue antibiotics for 7 days, continue antibiotics for 10 days, continue antibiotics for 14 days. Please select your option. Okay, wow, we have the answers everywhere. So we have 26 to stop the antibiotics. We have 10 to 5 days, and 26, 7 days, and 18, 10 days, and 20%, 14 days. Okay, great, so it's everywhere. Now, let me tell you my opinion. First, I will not stop antibiotics, despite it looks like it's not an infection. It looks like cow's milk allergy because there is, the blood culture is negative and there is no deterioration. The second is, but the possibility of infection is still there. Now, if you are old enough, you remember that when there was suspicion of neck, we continue antibiotics for 21 days. Then the evidence showed that there is no difference between 14 days and 21 days. So that's around 2010. From 2010, we found there is no difference between 10 days and 14 days of antibiotics regarding the outcome, the mortality and morbidity. And then from 2015 and forward, we found there is no difference between 7 days and 10 days of antibiotics. And we know antibiotics have side effects. You have resistance, especially the multi-drug resistance, and also the incidence of NEC are high. But in this situation, because I have still possibility of infection, because it's still low, I would start antibiotics for 5 days, and I would repeat the culture. And at the end of the 5 days, I would decide either to resume or continue for 7 days. So my option would be number 2, and then I will assess at the end, and I will see if I continue 5 days or I can go for 7 days. There is no reason to continue antibiotics with NEC unless you have infection, so it's not fun. But for NEC, you don't need to continue antibiotics for more than 7 days. But if you have a culture persistent, culture negative, positive, then yes, you need to continue antibiotics depending on the sensitivity and depending on the type of bugs. And then you can select the duration and you might change the antibiotics. But however, it looks for me this is cow's milk allergy rather than NEC. And I would continue antibiotics for 5 days. I would repeat the culture at 48 hours. And at the end of the 5 days, I would decide to start MEF or minimal enteral feeding for 2 days at day 5, or sometime I continue for 7 days and then I decide to start antibiotics. If 7 days is the same, probably I will change the milk. And if the mother is giving us BPM and she is take dairy product, I would ask her to stop dairy product for 2 days, and I ask her to express after that and give the milk. If still continue, I might try partially hydrolyzed. If it's continue, I will start with elemental diet, total land. If it's continue, I will stop feeding and continue the baby for a few days on TBN, and then I decide to resume. I hope answer the question. If you have answer, you can ask on the end. Case number 5. There are 2 babies here. Both of them are 1 day old. Both of them are 33 weeks. Both of them are healthy. They have no respiratory distress. The first one was born by C-section. There was no labor. And the reason for C-section, because mom has preeclampsia and she has placental insufficiency. The second baby, however, has P-prone and he has a preterm labor and he has intraamniotic fluid infection. The meconium was foul smelling and colored. Mom has maternal fever. She has leukocytosis and she has high ESR. So the question is, and please select your option, would you give antibiotics to rule out sepsis for 48 hours to number 1, patient number 1, patient number 2, you will not give both for anyone or you will give for both of them. So please select your option. And you can see here that I'm trying to give you different scenarios of different area of debate on antibiotics. Start antibiotics, indication of antibiotics, continue antibiotics, stopping antibiotics. And please, Mr. Moderator, if you can tell me my time. Remind me, please. Okay, so the 67% for option number 2 and 5% for option number 1, and we have 15% for number 3 and 4 for number 2. Okay. So here what I will do. I will not give antibiotics for both of them. However, I might do CBC for number 2. And if the CBC showing platelet or the white PC count less than 5,000 or the neutrophil less than 2.5 or the IT ratio more than 0.2, that's been more than 1 brand to mature 1 to 5, I will start antibiotics for number 2. However, with this scenario, without having the CBC, remember, if the baby born in bed, but he's asymptomatic, okay? The question here, the baby is 33 weeker. So if the baby is 33 weeker, I will do the sepsis workup for number 2. Okay, but if the baby is term, I will not do anything. So please remember that there is a risk factor for infection, but the baby is symptomatic, number 2. And the symptom is the prematurity. So I will do, in this scenario, I will do sepsis workup and start antibiotics. If this baby is term, however, and I will do CBC. And if the CBC show white BC count less than 5,000 or neutrophil less than 2.5, better. Do I have evidence? I would say this is a compromise decision. So in this scenario, I will go with the consensus of people, and I will do sepsis workup for option and give antibiotics for 48 hours until culture negative result comes back after 48 hours. So I'll go with option number 2.
Excuse me, sir. You have 5 minutes from now, please.
Okay. So
okay, thank you.
Okay, when I have time. Now the case number 6, a newborn looks sick on day 2 of life. Blood workup was done. Blood culture number were done. Ampicillin, gentamicin were started. The CSF white PC is 30 cells, protein 95, sugar 30, and glucose is, serum glucose is 50. The gram stain was negative. So after getting the CSF result, the baby is on ampicillin and gentamicin. Would you switch to ampicillin and cefotaxime? Would you add cefotaxime? Would you give monotherapy of cefotaxime, or you don't do change? Please give your option. Okay, show us the result. Okay, so most people, they will not change. And 30% will switch to cefotaxime, and only 22% number 2. So here what I will do. Now this baby has possibility of meningitis, but at the same time, he has possibility of sepsis. So I will definitely continue ampicillin and gentamicin, and I will add cefotaxime. And the reason, because both have no good penetration. And both ampicillin and gentamicin are synergistic. Ampicillin can cover listeria. And ampicillin and gentamicin both, gentamicin is good on staph, and ampicillin can synergize that. So in my opinion, you should add cefotaxime until you have the lumbar puncture result. Case number 7, you have 15 days old girl, 26-week gestational age. Her birth weight was 980 grams. She was noted to have a frequent apnea and looked off color. Blood pressure was low, and the basic cells was -8. She has a central line. She is on feeding antibian. Which empirical antibiotics you would select? You have 6 options. Please select. Okay, show us the result. Okay, so 51 for option number 3, and that's what I will do. I will start vancomycin because there is central line and the baby is 15 days old, so it's late onset sepsis, and I will add gentamicin to cover gram negative. And now the same patient, his inflammatory marker were increased. White PC were 6,000, ITs was 0.26. The absolute neutrophil count is 1,800, CRP is 120. But the blood culture and urine culture were negative after 48 hours. Patient receiving vancomycin and gentamicin. Would you change the antibiotics if the clinical status inflammatory marker improve? Or if the, so yes or no? And I will stop because I have more cases, but I will stop here with this case. So will you change the antibiotics if the inflammatory marker improve? Yes or no? Culture is negative, blood culture is negative, urine culture is negative, CSF culture is negative, but the CSF changes that you saw. Okay, so no, you will not stop. Now I will stop. The reason is the white PC count of all these findings that you saw, it can be normal for premature baby, the CSF finding. So if you have the CSF culture negative and the blood culture negative and urine culture negative and inflammatory markers improve, I will stop antibiotics. If the clinical condition deteriorate and inflammatory marker increase, will you change the antibiotics? Yes, no. Okay, show us the result. Okay, you will change the antibiotics. I think I will change the antibiotics. I will probably here go to meropenem or imipenem, depend on the whether the baby has CNS manifestation or not. What will be the duration of antibiotics? Remember, you have culture negative, you have urine culture negative, you have CSF culture negative, and the patient is deteriorating, inflammatory marker is increasing. So how long you will give the antibiotics? Okay, show us the result. Okay, so the answers are everywhere. I personally goes between 10 to 14, and I prefer 14 days because there is possibility of CSF infection despite the culture is negative. So I will change the antibiotics. I continue for 14 days or at least 48 hours. If later on the culture is negative, at least I have the repeated culture for 48 hours. So might go 10 days with 48 hours culture negative, or the best, in my opinion, here to go for 14 days. Now I have more cases. But unfortunately, I have no time. So I would later on, if there are no more questions that we have time, we can talk and discuss these cases. But I will be happy to answer questions. And so I have some, more cases. But unfortunately, there is no time. So I will leave the floor to the audiences, to the organizer, and I'm happy to answer questions at the end of the webinar. Thank you very much.
Thank you very much, Professor Yahya, and thanks a lot for your interesting and interactive presentation. I kindly invite the audience to write down their questions if they have more questions in the Q&A section, and also invite Professor Yahya to answer them by writing for the sake of time. So thanks again. So our second speaker is Professor Nu'man Nafi' Hamid. He is a professor in pediatric department in the College of Medicine, Baghdad University. He is a consultant pediatrician in Children Welfare Teaching Hospital, Medical City Complex in Baghdad. His presentation is about treatment and the prevention of bacterial sepsis in preterm infants less than 34 weeks gestation. So, Professor Nu'man, you can proceed with your presentation, and thanks in advance.
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
Good evening. Thank you, Professor Yahya Al-Ithaw, for very nice presentation. The diverse cases of different presentations. So talk about presentation, clinical manifestations, and diagnosis, and even treatment. So I will start giving presentation about treatment and prevention of bacterial sepsis in preterm infants less than 34 weeks. I declare no conflict of interest except that the ASINOB company sponsored this activity. So the objective of this presentation, I will give a classic lecture, but I think it will give some answers to the previous presentation of Professor Yahya. So we'll define the importance of treatment, prevention of bacterial sepsis in preterm infants less than 34 weeks. But I will not talk about late preterm or term bacterial infections. I will not talk about viral or fungal infections. I also will discuss briefly the supportive treatment. We'll discuss in details the empiric and organism-specific antibiotic treatment, and we'll discuss the preventive measures of bacterial infections in preterm babies, and especially the infection control measures, NICUs, and we'll give some summaries and recommendations as evidence-based medicine. So the bacterial infection and neonatal sepsis remain as a major cause of morbidity and mortality in preterm babies and very low birth weight infants. The clinical care provider should have a high index of suspicion to diagnose sepsis in preterm and low birth weight, very low birth weight infants, because delay initiation of appropriate antibiotic can worsen the clinical condition of the baby. The appropriate discussion, the approach discussed below is generally consistent with the guideline by the American Academy of Pediatrics. And these are the terminology we will use: preterm babies, less than 37 weeks, late preterm from 34 to 37 weeks, and very low birth weight babies are those who are born with birth weight less than 1,500 grams. And we'll discuss early onset sepsis as sepsis in the first 72 hours and late onset from 72 hours onward. And we have a special group, healthcare associated infections. They are infections which occur in the hospital while the patient receiving treatment for other conditions. And this is also the classification of low birth weight and regarding the gestational age and the birth weight. So the treatment of bacterial sepsis, we will talk about just below 34 weeks of gestation. The management consists of supportive care and the antibiotic treatment. And there are some controversies regarding the use of adjuvant interventions, but still, till now, there is none of the adjuvant interventions which had to prove to be effective in treating and preventing sepsis in preterm babies less than 34 weeks. What are the supportive care of sepsis we need? We need to ensure the adequate systemic oxygenation. We need to have adequate peripheral perfusion. And especially important is the aggressive resuscitative intervention for a patient with fulminant sepsis, who might die because of septic shock, who might die within 48 hours if not treated. What are the general supportive cares they need? They need optimal oxygenation. The patient might be stable. With sepsis, he might require to give him support, respiratory support by nasal cannula, or increase to CPAP, or even put him on mechanical ventilation and endotracheal intubation. Or the patients who are already on mechanical ventilator, we might need to increase the setting of the ventilator, or we change to another mode of ventilator accordingly. In a patient with concomitant neonatal pneumonia, surfactant administration might be useful to improve the respiratory function. The other general supportive measures include the maintenance of adequate perfusion. In a patient with inadequate perfusion, we give intravenous fluid resuscitation by administration of normal saline. After maintaining the adequate perfusion, we need to give ongoing management to have fluid and electrolyte balance. And there might be a role of inotropic drugs such as dopamine to improve the perfusion of the patient. So we should have adequate oxygenation, adequate perfusion, and maintenance of thermo-neutral environment. And you could see in this picture that the general supportive measures might include monitoring and caring for newborn in NICU, and these cares might increase the risk of nosocomial infections. So we might need nasal cannula, intravenous fluid, cardiovascular monitoring, and blood pressure monitoring, and different types of supportive measures. Though it's not present in Iraq or even the surrounding countries, probably it's present in Turkey, I don't know, but extracorporeal membrane oxygenation might be needed in certain cases of sepsis and septic shock. ECMO might be needed in a patient who was undergoing cardiorespiratory compromise despite maximal medical management. And the ECMO also needed for patients with severe refractory shock with the following criteria. If they have birth weight more than 2 kg, gestational age more than 34 weeks, and the duration of ventilatory support less than 14 days, and there is a diagnosis of, there is no diagnosis of irreversible. There should be irreversible lung disease. And there is no evidence of cyanotic congenital heart disease, and there is no contraindication to, there is no other contraindication to ECMO, like multiple organ system failure, contraindication to full anticoagulation, reversible pulmonary or cardiac disease, or multiple congenital anomalies. Then, after general supportive measures, we need to look for the source of infection and try to control it, because even if you give antibiotic, if there is a focus of infection, he will not improve. So sometimes we need to remove the focus of infection with antibiotic. So delayed removal of catheter, for example, CV line, or failure to remove the catheter, they are associated with increased risk of complication and persistent bacteremia. Then we said general supportive measures, and then the antibiotic therapy as a specific treatment. We have the initial empiric antibiotic therapy, and we have the organism-specific antibiotic therapy. But because of the increasing antibiotic resistance, the choice of antibiotic should be carefully selected. And then the antibiotic stewardship protocol, which is, I think it is used in certain countries, especially the developed like USA, Canada, and some, I don't know, but probably we are, I'm talking about Iraq, probably are not using the antibiotic stewardship protocol. They use, that's the use of early sepsis calculator. This is our calculator on an iPhone or on, which can be used. And also early discontinuation of antibiotic at 36 instead of 48 hours. All this will increase improve the condition and decrease the emergence of resistant organisms. There is one study in Frontier in Pediatric. They talk about culture negative early onset neonatal sepsis. They said there is no need to, there is a need to align the road. I mean, to have a balance between antimicrobial stewardship and giving efficient sepsis care. Because early antibiotic therapy for truly infected newborn is crucial for optimal outcome. On the other hand, prolonged antibiotic therapy for non-infected newborn is harmful to their microbe and their future, and to the community also. And another study, multi-center study in Dutch, they have Dutch guidelines about neonatal early onset sepsis. And they show that there is low adherence to the guidelines because they are, for those who require antibiotic, they are not giving. And because some of antibiotic, they are used for prolonged period in spite of negative blood culture. We talk just shortly about the antibiotic resistance, because there is an increasing emergence of infection in preterm babies, especially those below 34 weeks, caused by antibiotic-resistant gram-negative bacteria. In one study, they found that 85% of early onset E. coli infection, they are resistant to ampicillin. So what are the risk factors to develop resistance to antibiotic? Mainly very low birth weight, those below 1,500 grams, and the exposure to third generation cephalosporin. So there are two mechanisms for development of antibiotic resistance: chromosomally encoded or plasmid-derived ampis beta-lactamase and plasmid-mediated extended spectrum beta-lactamase. What are the extended beta-lactamase? They are primarily E. coli and Klebsiella. They are resistant. They will destroy the penicillins, the cephalosporin, especially third generation cephalosporin, second generation, and even the third generation cephalosporin. And also the monobactam, aztreonam, which is not available, I think, in Iraq, but it is similar to ceftazidime in its activity, and it is active against Enterobacteriaceae and then Pseudomonas and Klebsiella. So even they are resistant to aminoglycosides. So for extended beta-lactam and AMPS beta-lactamase producing organism, they can be effectively treated by fourth-generation cephalosporin, that is cefepime, and the carbapenems, especially the meropenem. Carbapenems, meropenem and impenem, they are a unique class of beta-lactamase agent. They are stable against most plasmid and chromosomally beta-lactamase and are effective against more than 90% of extended spectrum beta-lactam producing Enterobacteriaceae. Meropenem is the preferred carbapenem in newborn infant because the safety of other carbapenem have not been established in neonates. Although gentamicin resistance is not common, the aminoglycoside, other aminoglycoside like amikacin and nitlamycin, which are resistant to aminoglycoside, they can be used in a patient who are infected with gentamicin-resistant pathogen. So although they are resistant to gentamicin, but they can be sensitive to aminoglycoside, other aminoglycoside like amikacin and nitlamycin. What are the empiric antibiotic treatment? It should be initiated for infants who are suspected to have neonatal sepsis once the evaluation has been completed because of risk of death and severe morbidity. The initial choice of antibiotic depends on the leaky pathogen and the susceptibility pattern of the organism, in particular nursery. They usually do monitoring and surveillance of the antibiotics and the sensitivity of that antibiotics in this specific NICU, and then accordingly they will give the empiric antibiotic for early or for late onset sepsis. And then the presence of apparent source of infection like skin, central line, or bone, and these are more likely to be caused by organisms like Staph aureus and cons. So for early onset sepsis, the empiric antibiotic treatment is still ampicillin and gentamicin because they are effective against group streptococci and E. coli. And because of the emergence of cephalosporin-resistant organisms, especially Enterobacter and Klebsiella and Serrata, the use of third-generation cephalosporin to treat neonatal sepsis is not recommended, except when there is suspected gram-negative bacterial meningitis. And this is one of the answers to the question by Professor Yahya. So third-generation cephalosporin should not be used routinely. It should be used only for suspected gram-negative bacterial meningitis because there is very excellent penetration to the blood-brain barrier and to the CSF. There's one new study in JAMA Pediatric. They talk in 2020. They talk about early onset neonatal sepsis and the risk of E. coli, rise of E. coli sepsis, and the need for more effective preventive strategies. They found that early onset sepsis incidence and associated mortality disproportionately occurring in preterm babies, and there is limitation of the current preventive strategies for group streptococci, and there is an increase in the E. coli infection among very low birth weight infants. But still, the ampicillin and gentamicin are effective antibiotic in most of the in the NICUs and for specific organisms. So for late onset sepsis, the empiric antibiotic treatment will also depend on the organism, on the pattern of antibiotic susceptibility for particular nursery, and on a clinical setting. For late onset sepsis, the predominant causative organisms are cons, Staph aureus, and gram-negative bacteria. So the combination of vancomycin and gentamicin are the empiric antibiotic treatment for late onset sepsis. So this is also one of the answers to one of the questions by Professor Yahya. So for late onset sepsis, we have the cons, we have Staph, and you have gram-negative, so we'll give vancomycin and gentamicin. until the result of culture and sensitivity, and then you change accordingly. What are the alternative empiric antibiotics? We said early onset sepsis, we give ampicillin, gentamicin. For late onset sepsis, we give vancomycin and gentamicin. What are the alternatives? It depends on the additional clinical factors. If there is meningitis suspected, we should add cefotaxime, broad spectrum cephalosporin, third generation. If Staph aureus infection is suspected, we should give vancomycin or nafcillin or oxacillin as anti-staph. And if gram-negative infection is suspected or the course is fulminant, we have to add ceftazidime to cover potential Pseudomonas infection. Other alternative empiric antibiotic, in one study they found that in two studies, one, they give inadequate empiric antibiotic therapy as vancomycin. They are not included in the initial antibiotic as anti-staph for MRSA, and they have found that it was associated with increased 30 days mortality. Other study for late onset sepsis due to cons, they compare between giving vancomycin on the first day or they delay vancomycin treatment until the result of culture sensitivity. They found that they are similar. They did not, starting vancomycin the first day will not decrease the 30 days mortality. The antibiotic dosing depend on, for ampicillin, vancomycin, gentamicin, depend usually on the age and renal function. For ampicillin, the dose depend on chronological age and body weight, whether they are less than 7 days old or more than 7 days, whether they are less than 2 kg or more than 2 kgs. For vancomycin, the initial IV loading dose is 20 milligram per kg, and then subsequently will depend on the gestational age and serum creatinine. And we have to know that serum creatinine will represent the mother's renal function the first 5 days. So it depends on the gestational age, less than 28 days or more than 28 days with serum creatinine, will calculate the dose and giving according to the dose and the interval. Gentamicin also depend on the post-menstrual age and the chronological age, whether they are less than 30 weeks, less than 14 days, or more than 14 days. For those who are 30 to 34 weeks, if they are less than 14 or more than 14s, and depend the dose and interval depend on. After giving empiric antibiotic for early and late onset sepsis, the result of culture and sensitivity will appear, and then we change accordingly. So the antibiotic, according to the result of culture and sensitivity, we can start for cons, we will give vancomycin. For Staph aureus, methicillin sensitive Staph aureus, we will continue nafcillin alone. For methicillin resistance staphylococci, we complete on vancomycin. For E. coli, which are sensitive to ampicillin, we continue ampicillin alone. E. coli resistant to ampicillin, we will consider aminoglycoside, gentamicin, or broad spectrum cephalosporin like cefotaxime. For Klebsiella and Serrata, we use meropenem. If the organism is susceptible to aminoglycoside, we can start amikacin because it can also be sensitive, or fourth generation cephalosporin. For Pseudomonas infection, we use either gentamicin and ceftazidime or gentamicin and piperacillin tazobactam. So these are the empiric and the organism-specific antibiotics. I just want to add about ceftriaxone, the intravenous given over 60 minutes. We should not mix calcium-containing solution with IV ceftriaxone, and the intramuscular ceftriaxone should not be given IV because it contains lidocaine. Important thing regarding ceftriaxone, and it's present in previous articles and in Neofax Micromedics, they are talking about contraindication to ceftriaxone in newborn, especially premature babies, neonates with hyperbilirubinemia, current concurrent administration of IV calcium and IV ceftriaxone. As we said, we should not give lidocaine containing IV ceftriaxone. It's contraindicated. And there are certain precautions regarding the use of ceftriaxone. And this is doses for sepsis, for meningitis, and for gonococcal infection, whether it is uncomplicated or complicated gonococcal ophthalmia or gonococcal septicemia with or without meningitis. Duration and response to antibiotic. The duration of antibiotic therapy is usually 10 to 14 days for uncomplicated bloodstream infection. The length of therapy is longer in a patient with meningitis for 2 to 3 weeks for gram-positive, but for gram-negative meningitis should be minimum of 2 weeks, sometimes to 4 weeks. And the decision to continue antibiotic therapy in infants with negative culture is based on clinical judgment of the neonatalist. It's very important thing is the judicious use of antibiotic is strongly encouraged to decrease the prevalence of antibiotic-resistant bacteria and fungal infection. So we continue, we talk about empiric antibiotic, we talk about organ-specific antibiotic, and we talk about resistance, but there are certain adjuvant therapies to antibiotic have been used, but none has been shown to conclusively improve the outcome of infant with sepsis. Like IVIG, granulocyte transfusion, granulocyte colony stimulating factor, granulocyte macrophage colony stimulating factor, and pentoxifylline, all have been shown should not be routinely administered. The IVIG also depend on these studies. We don't recommend the routine administration of IVIG for neonatal sepsis. For granulocyte transfusion or growth factors, also, they do not recommend the routine administration of what they call pneumogene or other granulocyte transfusion or granulocyte colony stimulating factor or granulocyte macrophage stimulating factors here. So we don't recommend the routine administration of these. Pentoxifylline is xanthine derivative, and it is generally associated with sepsis due to gram-negative infections, but the studies till now prove that it is not recommended routinely also for treatment. What are the preventive measures? Our preventive strategies to prevent neonatal infections in infants less than 34 weeks. The only proven preventive strategy for early onset sepsis is the administration of intrapartum prophylaxis to the mother. The most current recommendation for national organizations such as American Academy of Pediatrics, American College of Gynae and Obstetrics, and Centers for Disease Control Prevention, all the administration of group streptococcus intrapartum prophylaxis or the administration of intrapartum antibiotic therapy to the neonate will not affect. It will not cause prevention of late onset sepsis. So what is proven is maternal intrapartum antibiotic prophylaxis as prevention for only early onset sepsis. And this is the intrapartum GBS prophylaxis indication: previous infant with invasive GBS, positive GBS screening culture during current pregnancy, unknown GBS status at the onset of labor, and any of the following. If the delivery less than 37 weeks, premature rupture of membrane, and prolonged rupture of membrane more than 18 hours, intrapartum maternal temperature more than 38, and intrapartum not positive for group B streptococci. So the neonatal practices to prevent late onset sepsis is important, and there is no rule for neonatal practices for late onset, but for early, regarding the early onset sepsis, we give maternal intrapartum, while for early and late onset sepsis, there is no rule to give any antibiotic or other adjuvant measurements to decrease the late onset sepsis. So for late onset sepsis and nosocomial infections, most important is the prevention, but especially for healthcare associated infections, that's mainly the nosocomial infections. They primarily focus on infection control measures. And these are the infection control measures recommended by the report of the American Academy of Pediatrics. They show that it will reduce the incidence of late onset sepsis. And what are the WHO recommendation regarding the prevention of late onset and especially nosocomial infections include that washing visibly soiled hand with soap and water, use alcohol-based hand rub for all clinical settings in which the hands are not visibly soiled, jewelries and watch should be removed, sleeves of the clothing should remain above the elbow, and every newborn should have his own dedicated stethoscope to be examined and need to be sterilized cleaned with alcohol before and after each use. Adherence to hand hygiene before and after direct patient contact is very important because handling invasive devices is important. Contact with body fluid, need to use gloves. Moving from one contaminated site to another during the care of the same patient, and after contact with inanimate surfaces and objects. The use of a glove does not replace the need for hand hygiene. So very important, hand hygiene and the use of a glove. And also the gloves are worn when there is reasonably anticipated contact with potential infectious materials such as urine, blood, CSF, stool. Gloves should be replaced after each patient contact, and there should be other preventive measures include don't wear artificial nails, and the natural nails need to be kept short, and promote education and feedback from the staff regarding the hand hygiene, and monitor healthcare worker hand hygiene adherence and provide feedback to improve their performance. And especially for those neonates on central line, to prevent catheter-related bloodstream infection, we should have the very important measures, the use of sterile technique and antiseptic agents related to line placement. Tubing should be replaced every 3 to 7 days. Catheters should be removed promptly when they are no longer needed. And we don't recommend routine use of antibiotic-like therapy for prevention of sepsis in neonates. The other measures include use of closed system of drugs delivery and promotion of, very important, promotion of early enteral feeding with breast milk. The other preventive measures include judicious use of antibiotic therapy. And most important is the restricting the use of vancomycin to reduce the prevalence of resistant enterococci, and also restrict the use of third-generation broad-spectrum cephalosporins, especially, because it is associated with increased resistance, except, of course, for when you are dealing with meningitis, we need to use cefotaxime, for example. Other measures of infection control, avoidance of crowding of the patients and the staff, and surveillance of nosocomial infection, continued quality improvements, And these are the summary of the principles for prevention of nosocomial infection in the NICU from Nielsen textbook of pediatrics. Observe recommendation for universal precaution with all patients. Nursery design engineering. Hand washing, we talk about hand washing in details. Minimize risk of CVC line, also we talk about it. Meticulous skincare of the newborn. Encourage early and appropriate advancement of enteral feeding, and education and feedback for the nursery personnel. And continuous monitoring and surveillance of nosocomial infection rate. What are the mostly the organisms in the cultures and their sensitivities. Other preventive measures which has been postulated but it is not proved as prophylactic therapy include lactoferrin. Still the studies, we need more studies to give recommendation regarding the use of lactoferrin and probiotic. So we will not suggest using these therapies.
Sorry, sir, you still have 5 minutes.
Okay,
Professor
I will
Hamad,
finish.
please.
Okay, I will
Thank you very
finish
much.
within less than 5 minutes. Okay.
Okay, thanks.
Okay. So for probiotics, we also not routinely using probiotic for prevention of late onset sepsis in preterm infants. The efficacy of probiotics in preventing late onset sepsis are reducing mortality. There is concern about the uncertainty about the appropriate dose, the selection of the specific organism, the safety and the regulation of these products. And so, and there is also rare serious cases of probiotic associated sepsis. So we suggest not routinely using probiotic for purpose of preventing late onset sepsis in preterm infants. And this is a position paper by Espigan. They are not recommending, because the panel conclude that there is no recommendation can be made in either direction regarding the use of Lactobacillus reuteri DSM 17938 to reduce mortality, NEC stage 2 or 3 or sepsis. And there is no recommendation can be made in either direction regarding the use of combination of Bifidobacter bifidum or Bifidobacter longum to reduce the risk of mortality, NEC, or sepsis. And this is from the American Gastroenterology Association regarding the use of probiotic. They also they found that the combination of certain species might be effective in reducing NEC, but not for sepsis. And we have the summary of the recommendation. General supportive measures for preterm bacterial sepsis include maintaining optimal oxygenation, adequate perfusion, and thermo-neutral environment, and the catheter need to be removed when not needed. We recommend preterm infants suspected sepsis be treated with antibiotic, empiric antibiotic therapy. The antibiotic therapy for early onset sepsis, group B streptococci and E. coli. And for late onset sepsis, we have Cons, Staph aureus, and gram-negative. So the empiric antibiotic for early onset sepsis should be ampicillin and gentamicin. And for late onset should be vancomycin and gentamicin. And alternative regimen including nafcillin or oxacillin and gentamicin to replace vancomycin. Antibiotic is altered based on the isolation of the causative organism and the sensitivity, and the duration depend on the result of culture and clinical condition. Uncomplicated bloodstream infection, duration 10 to 14 days. Infants with negative culture and the patient is stable, we can stop antibiotic, and should be discontinued if the patient appearing well and the culture is negative after 48 hours. And we suggest not routinely using IVIG, granulocyte transfusion, pentoxifylline. And prevention of neonatal sepsis due to healthcare associated infections primarily focus on infection control measures, including hand hygiene, adherence to guidelines for insertion of CV lines, judicious use of antibiotic therapy, and these are the evidence-based grade 1B strong recommendation and grade 2B is a weak recommendation. And thank you very much for your listening. Thank you.
Many thanks, dear Professor Nu'man, for this nice and interesting presentation and for the valuable information contained in it. I invite the respectful audience also to write down their questions in the Q&A section. And Dr. Nu'man, please, if you kindly answer the questions if they are written in the Q&A.
Okay.
So allow me to come back to our respected speakers in case there is any other question, whether to the speakers or to myself. Please go ahead and write them down in the Q&A. I'll start with reading the available questions, and of course I'd like to thank Dr. Yahya Al-Ithawi very much and Dr. Nu'man, because I see that almost all of the questions were answered by typing by them, so many thanks to them for their contribution in answering your questions.
I have one comment if you...
اتفضل أستاذ, please.
I would preclude from mentioning doses in neonatology, because whether it's a ceftriaxone or any other antibiotics or any medication, it depends on the gestation, depends on the weight, it depends on the postnatal age, it depends on other circumstances, whether you're using it prophylactic or management, and also the type of infection that you're using it. So the dose ranges between 25 to 100, and the duration varies. It depends on the scenarios. And again, so do not take the dose as granted. Try to use Lexicom or UpToDate or any live resources for doses, and don't take the dose as a grant, because I see one person is asking about the dose. I can send you all the doses of ceftriaxone and the studies that have been done on these doses, depending on the situation, the scenario, gestation, postnatal age, and others, and also the indication. That would be my comment.
Thank you very much. And you have answered the question that is asked here by anonymous attendee about the dosing. So many thanks, Dr. Yahya, for your contribution. I cannot add anything more than what you have said. Thank you. And another question by Dr. Kashif Habib: why ceftriaxone is usually not recommended in neonatal age? I think we have been through this point and we have discussed it. It is not recommended. Actually, there are some concerns regarding whether the baby is premature or not. It is contraindicated, as I said, in premature babies with the corrected age less than 41 weeks. Otherwise, it is not contraindicated. And if you think that it is effective against the expected bacteria, you can use it empirically. And if you have a positive culture and sensitivity mentioning that the bacteria is sensitive to ceftriaxone, you can use it. And if Dr. Yahya or Dr. Nu'man can correct me, please go ahead.
So I would say that there is a difference between contraindication, not recommended, and if you have a compatibility issue, or use it with caution. So the only contraindication that I think is present is allergy. You have to use it with caution when you have a jaundice, because it displaced the bilirubin from the protein, with increasing the free bilirubin, causing possible kernicterus. And that's one. Then you have a compatibility issues with calcium if you're using TBN. But if you have two central lines or one central line and peripheral, there is no problem of using it. There is always precautions when you do have cefotaxime, and if there is a review after they will ask you why ceftriaxone, not cefotaxime.
Yes.
So I don't think there is contraindication other than allergy. The other things are precautions and compatibility issues.
Yes, we already said there's a few contraindications, as we said, prematurity, jaundice, and using with calcium fusion on the same line, as you said.
Yes.
But in general, we can use cefotaxime instead of ceftriaxone. Yes. We can use it.
Available, it would be hard to justify we're not using it.
Yeah.
So sometimes it's not available, or
yes.
Some units, they don't have, like, they won't use it, like, for example, in the postnatal care, and You don't have the frequency of administration, so that would be a cefotaxone because less frequency. It's a little bit, better option in that scenario.
There are reported 6 cases of death due to combination of calcium and
Yes.
ceftriaxone.
There is a compatibility issue. I agree with you.
Yeah, and they said it might be probably because of the high dose of ceftriaxone. They use it up to 200 in the 4 of 6 cases. So probably the high dose they use, not because of other, but should not be mixed with calcium infusion on the same line.
So it is a
within
misuse
48
case.
hours.
If the dose exceeds 100
it is
milligrams,
reported
so it's a misuse.
Yes.
I mean, I would very be careful when I say not and use. Medicine is about ambiguity. We don't know. So always stay open and be careful what you do. But I don't think ceftriaxone should not be used in neonatology, but it should be used with precautions, and you have to justify it.
Thank you very much, Professor Yahya, Professor Nu'man. We have other questions, if you allow me. An anonymous attendee is asking, what is the best management or antibiotics for necrotizing enterocolitis?
Okay, so enterocolitis usually happens somewhere between, the average is 21 days, and the mean between 11 days and probably 36, 37 days, the range. Very unlikely, it can happen, but very, very unlikely before 11 days of age, and very unlikely when you go to the term. However, when you are term and you have risk factors such as congenital heart disease or other reasons of compromising the perfusion to the bowels can happen earlier at that age, but usually more in term babies. The reason why we start antibiotics with the necrotizing enterocolitis, because there are 3 proven association. 50% or 35 to 50% of necrotizing choroiditis blood culture are positive. That's one. The second is mortality is high when not using antibiotics. The third is post-mortem and surgical. When you do a surgical intervention such as primary peritoneal lavage or Penrose, or you do resection, you find like there is abscesses, and so there is evidence of, and in post-mortem too. And that's the reason why we used antibiotics. So the best management is like any sepsis. So if you have early onset sepsis, then it's ampicillin and gentamicin. If it's a secondary onset sepsis, and whether you have or you don't have an IV line, central line, then you decide vancomycin and gentamicin. You might decide to go with other options. So you have peptazole that can cover both the same action of ampicillin and gentamicin, or sometimes you can add meropenem. Why I don't like meropenem? Because of the resistance that can appear, and it's the final weapon that you have. And the second is I'm very hesitant to start monotherapy for necrotizing enterocolitis. People are very concerned about metronidazole. I do not use metronidazole in 25 years of neonatology practice for sepsis in neonatology. And in 10 years, I either used 1 time or 3 times, 1 to 3 times in 10 years, I used meropenem. Because remember, using antibiotics and people are finding excuse of using antibiotics, such as I am in Iraq, such as we are not having infection control, and that is wrong, totally wrong. You're contributing of having bad neonatal outcome. And remember, when baby is deteriorating, we are talking of a deteriorating baby with a proper support. So if you don't have proper respiratory support, that does not mean the baby is deteriorating. If you have PDA and you're not managing it, that is not deterioration. If you have a low temperature, that is not deterioration. If you don't have good incubator, that is not deterioration. If you cannot keep humidity, that is not deterioration. That is the deterioration not because of the antibiotics, that deterioration because you don't have proper support. And antibiotics will not save the baby. So you need to go with the guidelines. You need simple combination. Ampicillin and gentamicin is the best combination. You go. And if you have a line and it's a late onset, vancomycin, and people are concerned about renal function, you have to do gentamicin level at dose 5. And if you have facility, you can do it at dose 3. For vancomycin, you can check the level. If you don't, and you have to see if you don't have level, you don't have facility to do level, do renal function and adjust the dose to the renal function. Okay, I think I'm finished. I can keep talking about antibiotics for 2 days.
Thank you very much, Stad. Actually, we have more questions, if you allow me. Dr. Ahmed Shamran is asking, can we use ceftriaxone in neonates with congenital hepatitis associated with increased liver enzyme plus evidence of infection, including fever plus increased white BC with neutrophilia, and what is the dose?
You can use the ceftriaxone if you don't have jaundice, if you don't have compatibility issues, and you don't have allergy. Cefotaxime and ceftazidime are same of cefotaxime. Ceftazidime more with cover of Pseudomonas, but both, all the three are broad spectrum. All three cover more negative than positive. So whenever cefotaxime is indicated, ceftriaxone is indicated, but be careful of the circumstances. What is the dose? This is probably serious infection, and I would go with a high dose. So I would consider this as a meningitis dose, and if the baby less than 14 days, I would give 50 milligram per kg per dose. If the postnatal age more than 14 days, I would give 100 milligram per kg per dose. For the first dose, and I drop it probably between 80 to 100 for continuation of the dose, because this is a very serious infection.
Okay, thanks a lot. I shall take the remaining questions, and from Dr. Masha Al-Qasir, she's asking, in case 3, what about the prolonged rupture of membrane?
Okay, so in infection of neonate, we're talking about 2 different things. First, we're talking about ruling out sepsis. We don't have sepsis yet, but we are ruling it out. And we start antibiotics because when the culture came back positive, and if we're waiting to give antibiotics, too late. So please don't mix up between treating sepsis and treating to rule out sepsis. So first, we are giving antibiotics at birth to rule out sepsis, not to treat sepsis. So we give it 48 hours. And the reason why 48 hours, you can go longer if the yield, because up to 90% of culture will come within 48 hours. Now, if your yield of blood culture longer than that, you can go 72 hours. So that's one. So the rule out sepsis is depending on 2 factors. First is risk of infection. Second is symptomatic. So do we have risk of infection? That's one. Second, is the baby symptomatic? If the baby is not symptomatic, no need for antibiotics. If the baby is symptomatic, then you need to rule out sepsis. Again, baby born not because the premature, baby born in a sewage, baby born and fell down in the sewage. No antibiotics, unless the baby is symptomatic. You're driving in the street, you are at risk of car accident, but you don't have car accident to repair your car. You cannot repair it because of it. So if the baby is asymptomatic, there is no need for antibiotics. And the reason is because you will develop a resistance and you'll have more death. The second is the breastfeeding or the formula feeding and antibiotics is the only approved risk for necrotizing enterocolitis, and necrotizing colitis is a disease, killing disease. The other things, the baby is not going home. The baby is in an ICU. So if there is a deterioration, start antibiotics. Okay? So if there is a risk factor and there is symptoms, even one, I will start antibiotics. So for example, baby is less than 37 weeks, prematurity. However, the prematurity should be because there was labor. Because if mother is hypertensive and you do section and you get prematurity, that is not symptomatic. So prematurity in spontaneous labor considered symptom. Respiratory distress, hypoglycemia, temperature swinging, fluctuation of temperature. Other presentation, you do sepsis to rule out sepsis, 48 hours antibiotics. Now, there are other factors is prophylactic antibiotics. Not you're giving antibiotics such as neutrophilia, such as bowel surgery pre-surgery, such as contaminated procedure. That is not called antibiotics. That's called prophylactic antibiotics. So please don't mix up between rule out sepsis, treatment of sepsis, prophylaxis antibiotics, surgical antibiotics. These are two different issues. And the reason why they are different, because the duration are different, the dose are different. And why this is important? Because of the side effect of the antibiotics. You will develop MDR. You will get more neck, and that's cause killing. Okay? And remember, we're not telling you to discharge the baby. So if you have risk factors of infection and the baby is asymptomatic, do sepsis CVC and monitor the baby for 48 hours. And if they develop symptoms, start antibiotics to rule out sepsis. So you have to be careful with the terminology. This is my answer to Dr. Ahmed Shuan, I think.
Shamran.
Dr. Ahmed Shamran.
Hey.
Welcome back, Dr. Nu'man.
Dr. Misha'il, she's asking me about case number 3. Same answer.
We still have 3 questions. Do you have time to answer them, Professor Yahya, Professor Nu'man?
Yes, please. Nu'man, you can answer if you want, please. If you can comment on whatever I said.
Okay.
Yes, I just wrote typing on for answering, yes.
Oh, thank you for that. Okay. Dr. Faiza Khattab is asking, what about acidosis and hypoalbuminemia and use of ceftriaxone in neonates? I think I have mentioned this point.
Yes, you already mentioned
Dr.
this.
Nu'man? Okay.
Yes. Yes.
So these are risk factors of having displacement of bilirubin from
binding site, yes.
Yes, from its
will exaggerate the jaundice, yes.
Yes.
So you cannot justify it, if in this case, you cannot justify use of ceftriaxone if you already have cefotaxime and ceftazidime.
Yes, you can use
if you don't, then you can justify it.
Yes.
Okay.
Clear. Okay. A question from Dr. Ijeoma Obemnimi. He's asking, what exactly is the problem with metronidazole in management of NEC?
Okay, well, metronidazole is not a broad spectrum antibiotics. That is one problem. So using it can cause resistance. That's one. Second is the side effect. The side effect, the metronidazole can cause peripheral neuropathy. Okay, and you don't need it. You need it when there is no other option. You have culture and sensitivity, and it's only sensitive to metronidazole, and you have perforation. I know the surgeon love it, I know, but you know what? I never used it unless the surgeon is pressing on me and I am kind of making a compromise decision, and I use it for a short period of time. So go with the principle, go with the combination. I rarely ever use metronidazole, triple therapy unless I talked with infectious disease specialist and I have very solid reason, including sensitivity. I don't see a point of using metronidazole for neck. Okay, and we're talking about neck, we're talking which grade of neck? We're talking about neck with perforation. And with that, also, I don't use it. Okay, go ahead, sorry.
Another question from Dr. Sara Fauzi Kadhum. Again, she's asking about ceftriaxone. Can we use it in liver impairment? I think this is close to the previous question about viral hepatitis.
You cannot justify this using it with liver impairment, including the risk, and you have other options. If you do have other options, you have to use it. But if you don't have options, okay, and you have liver problem, but the albumin is okay, and you don't have acidosis, and the bilirubin is okay, you still can use it, I think.
Okay, thank you. A question from anonymous attendee. No, she answered, she wrote her name, Dr. Fatma from Pakistan. My question is that in our practice, if a patient developed NEC and we added metronidazole and after a few days, patient gets improved slowly. It is very common here in our practice. She is describing her practice in Pakistan. So what do you think, doctor?
So first neck will not resolve within a few days. So if it's resolved, that means it's not neck. Okay, that is a feeding intolerance or maybe allergy to milk. Neck will not resolve in less than 7 to 10 days if it's neck. And if neck with perforation, it would take 21 days or maybe longer. And it needs surgery. The surgical option, either Penrose or a primary peritoneal lavage, or you do exploration and maybe you do resection and with that. If it developed within few days, please mean that is not neck. So that's very important. And remember is why you're giving metronidazole. There is no option, there is no reason, there is no indication. Yes, the indication of metronidazole is a parasite, liver abscess. These are the indication of metronidazole because they can treat it. And when you have perforation, but when you have perforation, it's due to neck. It's not due to infection. You're treating already the infection. So if it's an early onset sepsis, it's an E. coli or some gram-negative coming from them. It's a late onset sepsis. It's either Crohn's or staph. It can be gram-negative, I'm not saying. But remember, all the presumed infection are either E. coli or GPS or staph, whether it's Crohn's, whether it's a MRSA or MESA. If it's rare other bacteria, then you need sensitivity. You cannot start antibiotics before rare bacteria unless you have antibioma in your facility. You have cultures and you know what is the most common, and you meet with your microbiologist and ID specialist and you decide, no, that is the best option. I'm not against that. But in general, in whole globe, ampicillin and gentamicin, vancomycin and gentamicin if there is a. Now, if the baby is outborn coming from the community, that is different. It should be ampicillin and cefotaxime. That is different story. But I'm talking about NICU patients.
Yes.
So I hope that I answered your question about metronidazole. What are the other?
Thank you very much. And we have finally the last, not a question, but a comment from Dr. Tololo Ogendili. He's saying that please differentiate between presumed sepsis, risk of sepsis, and is there need for antibiotics?
Okay, so presumed sepsis means that we have symptoms, and this symptom might be due to infection, might be due to other factors. So for example, we have premature baby and mom was in labor. This labor can be due to infection, but it just cannot be. We don't know why premature labor happened. Now in COVID-19 pandemic, the prematurity coming down. That was the latest report.
Yes, 90% reduction.
So the prematurity might be due to other reasons. So now we have a presumed sepsis because you have a premature baby and it might be due to sepsis, it might be due to sepsis. So what do? We do blood culture to exclude sepsis, but we cannot wait until the culture come back. We have to give the antibiotics just in case it's due to infection. So that's called presumed sepsis. Now the risk of sepsis is prematurity. Mother have prom more than 18 hours, or mother is febrile, or mother is GPS positive, or the mother is foul smelling, or the mother have leukocytosis, or have tender uterus. These are risk of sepsis. Or the risk can be postnatal. You're doing surgical intervention in the bowels, or you're doing a contaminated procedure, and so on. So these are risk factor. But when you have risk factor, you have to give prophylactic antibiotics. It's prophylactic antibiotics mean limited dose, limited duration. That is prophylactic. Surgical antibiotics mean before and after surgery, maybe 1 or 2 doses. That's all. But remember why we're doing this, because giving antibiotics is killing the patient, not directly, but indirectly. And also you can develop neck. So please remember, drug resistance, you get the MDR, multi-drug resistance, or you can get SPL, or also you can get neck.
So thank you very much, Professor. This was our last question for today. In the last, I'd like to first thank you very, very much our respected speakers, Professor Dr. Yahya Al-Ithawi, Professor Dr. Nu'man Al-Hamdani, for your time, for your dedication, and for your contribution in this webinar. I'd like also to thank our respectful audience for their attendance and for their participation in this scientific webinar. And last but not least, I'd like to thank the supporters of this webinar, represented by the pediatrics departments of the medical colleges of the following universities: University of Al-Anbar, University of Baghdad, Al-Basra, Babylon, Duhok, Kirkuk, Kufa University, Al-Qadisiyah University, Mosul University, Sulaimaniya, and Tikrit. Thank you very much, and we hope that we see you again in the future webinars. And thanks again. Thank you.
Thank you very much.
Thank you very much. Have a good night.
Thank
Stay
you.
safe.
Have a good night, everybody.
Thank you. Stay
Bye.
safe.
Be safe.
Good night. Bye.
Okay. Thanks.